Good morning. Welcome, everybody, to the meeting of the GM Joint Health Scrutiny Committee. This is the first meeting of the 1920 municipal year. I'd like to welcome all members, particularly our new members that we've got on the committee today. We have Councillor Linda Thomas from Bolton. Welcome. Councillor Eddie Moores from Oldham. And we have Councillor Stephen Homer, but unfortunately he's not here. He's had to send apologies. Other apologies for absence that we've got is Councillor Eve Holt from Manchester City Council. Unfortunately, she has got another meeting this morning. I think we just wanted to place on record thanks for the last members that were on the committee that have virtually stood down from the committee from last year. So we have the former Vice Chair of the committee, Councillor Colin McLaren from Oldham. We have also got Gillian Peat from Tameside, who's no longer with us, and she's just actually stepped down from all council duties over there. And we have Councillor Stephen Pickup from Bolton as well, who's no longer on the committee. So thank you on behalf of everybody here for their work that they did last year. Okay, so we need to go on now for nominations for the chair of the meeting. Do we have any, please?
Councillor O'Brien.
Councillor O'Brien, is that seconded by anybody?
I'll second that.
Thank you. So we appoint Councillor O'Brien for the next municipal year for the chair. Do we have any nominations for the vice chair, please?
Margaret Morris.
Seconded anybody? Okay, so Councillor Morris appointed as vice chair for the committee for 1920. Thank you. Okay, so just on to the normal meeting business now. John, can you take over, please, and just go us through the membership and members' code of conduct and minutes from the previous meeting.
Thank you. You were all sent a declaration of interest forms. Have you filled it in and brought it? Have you got them back?
Yeah, thank you to those that I've got. If I could just remind other members if we could have them by close of play this Friday, please.
Okay. It is important because otherwise we're in trouble, you're in trouble. It's mostly what you've already done for your local authority, but just send a copy across, please. Somebody move the minutes from the last meeting. Ray? Thank you. Seconded. Good. Matters arising from the minutes? None. There you go. Look at that, Jackie, you're on. Alfie?
Good. It's still morning. Yes, good morning, everybody, and thank you for inviting us here today. My name's Anthony Hassel. I'm the accountable officer at Salford CCG, but for the purposes of today, I'm here as the commissioning lead for this programme, Improving Specialist Care, which I'm delighted to be able to give you a briefing on in terms of where we are up to. I know we've engaged with the Joint Overview and Scrutiny Committee previously, but of course with some new members, it's really important that we make sure that you're all up to speed. I'm particularly pleased as well to see Councillor Gruby from Derbyshire, because of course Greater Manchester isn't an island, and whilst sometimes I think we think we are an island, there are particularly patient flows from outside of Greater Manchester which are important that we bear in mind and consider. So Jackie and I have got some slides that we're going to go through. We'll go through those slides and then happy to answer any queries or questions. Okay, so what's this programme about? So as I'm sure you are all aware, hospital services in particular have been changing for the past 30 years and will continue to change. The NHS is one of those organisations that is changing constantly, not least because of the nature of the patients that we serve, but also because of things like constraints around the availability of workforce, new technology, new drugs. And you'll know that in Greater Manchester we've been really, I think, brave in making a number of decisions over a number of years that have improved the care that the NHS can offer. So, for example, we have made changes around stroke services, which have centralised stroke services in a number of hospitals. We have made changes around major trauma services, which mean that we have centralised expertise into a fewer number of sites to enable us to give much better care to anybody who suffers, who unfortunately suffers any major trauma. And this programme is part of that continuum, which is for particularly surgical or perhaps once-in-a-lifetime events. It's about creating centres of surgical excellence across Greater Manchester, where surgeons can work with other clinicians to ensure that we are optimising the outcomes that patients can expect. And we've been working for a period of time on a number of specialties, and you can see them listed in the box on the slide. And what you may note about the majority of them is, as I've described, they are broadly surgical specialties, so responding to conditions that require a surgical intervention. Of course, we've got up there respiratory and cardiology. Those aren't surgical specialties, but in those particular areas, what we're looking at is improving the standard of care that is offered in each hospital across Greater Manchester, because we know there is currently variation. So we've been working with clinicians of all different types, not just doctors, but nurses, allied health professionals and others, primary care clinicians as well, to develop what we are calling models of care, which describe an optimum model of care for each of these clinical areas, where we really think that by implementing these models, we can improve outcomes, reduce variation, and frankly, in line with changes that we've made previously, save lives. So we've been developing these models of care over a period of time. We've also developed a set of evaluation criteria, including things like quality, access times, estate and deliverability, workforce, that we're using to take these models of care and understand where we can deploy them best. And we're in that process. And what we hear constantly and importantly is that, of course, in all of this, access is really important to local people and indeed their representatives. And we've been working very hard with Transport for Greater Manchester to ensure that we can properly understand issues around access and include them in the analysis that we're undertaking. So, alongside the development of these hospital-based models of care, of course, what's really important is to ensure that we have complementary and enhanced services outside of hospital. And you'll know across Greater Manchester, every borough is developing either a local care organisation or an integrated care organisation, which is broadly about making sure that we improve standards of care outside of hospital. And part of this programme is ensuring that that happens in a consistent way, and indeed that those enhanced models of community provision are available in advance of any changes to hospital care. And of course, that also includes ensuring that we maximise the richness of ensuring that people are able, where possible and where they can, to look after themselves. So, as I've said, what we're hoping to do through this programme is to address variation and reduce it, but also develop a further series of centres of excellence across the conurbation that we can look to deliver the absolute best for the population of GM and beyond. So, this next slide looks rather complicated, but what it's hoping to describe is the process that we're going through, where we have some models of care developed by clinicians, informed by expert clinical advice and guidance, but which don't say where services should be delivered. What this slide is trying to do is to say we are going through a structured process of enabling us to use different types of information, different types of data, but also looking at decisions that have already been made particularly around things like Healthier Together and the centralisation of emergency surgery, the centralisation of cancer surgery on a limited number of sites. Looking at all that type of information to develop a series of options, which Jackie will talk about, around how we then take these models of care from almost a theoretical model into how do we deploy this across Greater Manchester. So what we're doing is using a very structured approach, informed by data, informed by information, to enable us to narrow down to a limited number of options, which then we may, subject to obviously discussion with yourselves and also with NHS England, need to either do very robust public engagement, and I will talk about some of what we've been doing on that already, but indeed some of these changes may require formal public consultation. But as I say, it's really important in the development of these proposals that we have active conversations with local people now, and we don't wait until we are formally required to have those discussions. And I'm really pleased that we've been able to pull together different groups, including representatives from organisations such as Healthwatch, but also including ordinary people who have used some of these services already as we have been developing these proposals. And indeed, Jackie and I were at a session on Monday where we had a group of patients from all parts of Greater Manchester together discussing the views that they may have as we move this programme forward. And as you can see, we've been testing views from those groups along the way, and there's some analysis there of some of the things that people are already saying. So broadly, I think when explained, people are saying, we get this, we understand why you're doing it, and we think there is a strong case for change in some of the areas that we're talking about. So I'll hand over to Jackie, who's going to go through some more of the slides.
Thank you. Good morning, Jackie Benet from Bolton, but actually provide the leadership for the delivery arm of this programme. This is quite a complicated slide. I don't know if you've got it in front of you, but I can talk you through the various options. So you remember Anthony's just talked about the specialties and the evaluation criteria that was applied. That took us eventually to 8 options, but you can see just 4 there, and that's because we've taken out so far to do some more work on the orthopaedics and the cardiology specialties. They need more work, and that's been agreed through our governance processes, and commissioners have agreed this in months gone by, and we're doing more work outside of the programme on those, largely on workforce and the sort of spread of the models in orthopaedics. But taking those out doesn't affect the overall programme, and we were quite keen to crack on with some of the other specialties which are becoming quite difficult to provide across a whole conurbation, particularly breast services. So we're trying to keep the programme going, and then we'll add the other 2 back in later on, but they don't change any of the options. So if they were all there, you'd have the same breast options at the top, and then the same breast options again, 1, 2, 3, 4. But so you don't need them when you've taken the 2 options of orthopaedics out. So at the moment, we're going to add MSK and cardiology back in later on, but we have got a number of options here. But several of these services, we can describe the sites that they would or could be delivered in because of the model of care itself. So to explain that, I'll just give you an example of urology, for instance. So urology is currently provided on an inpatient basis, and the surgical element of it across a number of sites. And because in the model of care, the clinical proposal was to rationalise that for the reasons Anthony's explained to you, down to 5 sites. Because of decisions already taken around Healthier Together, that is the configuration or the consolidation of emergency and high-risk surgery, which we've taken before as Greater Manchester, the Healthier Together sites should also, because there's a codependency of urology surgery with emergency and high-risk surgery, should be on the same sites. And that takes you to the proposal that 4 of the hubs of the 5 hubs in that model of care should be Manchester Royal Infirmary, Oldham, Salford and Stockport, because these are the Healthier Together sites for high-risk and emergency surgery. Bolton is in there as a 5th site because it is a provider of high-risk obstetric care, and that is the case also with Oldham and St Mary's in Manchester. There are 3 sites that provide high-risk obstetric care, and the clinicians do feel that there's a high likelihood of needing urology expertise with high-risk obstetrics. So you can see how the clinical codependency works there. Now, the other sites are not Healthier Together sites. They're not going to be receiving emergency and high-risk surgery in the future, nor are they high-risk obstetric sites. And therefore, in the model, the proposal is that there's 5 hubs and the rest are spokes. So some inpatient services may move as a result of this if this is agreed later on. But in the model at the moment, 5 hubs, and those are the sites that they would be delivered from. In terms of paediatric surgery, it's a similar explanation, really. In that model of care, you would have a high-risk super centre, tertiary centre, which can only really be provided by Manchester Children's Hospital. So that's a high level of expertise with low-volume, complex surgery that should only be provided by real experts that are doing those operations many times. But you also need some expertise around Greater Manchester that deals also with high acuity surgery that can't really be delivered in smaller sites without a sort of next level of expertise. And the proposal in the model of care was 1 super centre, if you like, a tertiary centre, 3 high acuity centres, and the rest low acuity, which is what the offer is now in most hospitals. So day case surgery, outpatients, etc. for children would all still happen where it's happening now. In terms of the choice of the high acuity sites, because in the model it's 3 sites, it was felt that the best sites for these were the ones that already have the high risk obstetrics and neonatal care, because they've got developing complicated paediatric services, that being Oldham and Bolton, as I've just explained, but Stepping Hill also because it's a Healthier Together site. So there's some surgical work going on there. Now, you remember the Healthier Together site is also Salford, but there is no obstetrics at Salford. So that's why Salford isn't there as a site. So in a sense, the high-risk centre is the Children's Hospital, which it is now, and then higher acuity for some more complicated but not the very complex operations in Oldham, Stepping Hill and Bolton. The respiratory pathways are in this, but they don't affect hospital sites at all, because these are about improving the standards of care along 3 clinical pathways generally: chronic obstructive pulmonary disease, pneumonia, and how we vaccinate our populations against flu. All needs to be taken to a higher standard and to be equal across Greater Manchester. And so these actually affect more community pathways than they do hospital pathways, and that's quite right too. In vascular, the model of care, and this was very much supported nationally, for a major arterial centre for a population of this size should just really be on 1 site. And that site needs to have inpatient 24/7 cardiothoracic intervention and the ability to put people on dialysis immediately because of the nature of the surgery. And that can only really be provided in 1 site in Greater Manchester, that being Manchester Royal Infirmary. But we do need to have sites that will provide some vascular work, not necessarily day case, but some operations that aren't the major risk operations. These are, again, coming back to the Healthier Together sites: Oldham, Salford, Stepping Hill, and Wythenshawe, because it has a cardiothoracic centre there as well, so that can support Manchester Royal Infirmary. In neuro rehab, that is a little bit further on in terms of process and has already been through a governance process, so we're setting about the business case. But again, the model of care was having a high site to support neurology, and there is a designated centre in Salford already around that. So the sort of high complex neurorehabilitation should take place on the Salford site, with a step-down site in Trafford was the proposal, and this has already been accepted by commissioning colleagues, and we're working up the business cases. So I'll take you back to Brest at the top, because this is probably the most complicated one and where there are a number of options. So the rest of them, the sites are kind of determined by the models, but there are options around Brest. In any scenario, in any option or configuration, Wythenshawe should always be there. Wythenshawe is a nationally designated centre for breast surgery. It provides quite complex surgery, again, low volumes of very complicated surgery as well as general breast surgery. And there are some particular interventions and particular expertise that exist in Wythenshawe that we wouldn't want to disrupt. So Wythenshawe is there in all the options. But there are some options in the other 2 hubs. So the model of care is describing 3 hubs across Greater Manchester. Breast services at the moment are patchy in terms of the provision of surgery and the diagnostics, and they're not always in the same place, but this model of care proposes that they should be. So our patients should not be having to go to a number of different hospitals for different bits of the pathway. In this model of care, it's almost like a one-stop shop where you go once, you go and have your diagnostic, your intervention, be that a biopsy or some other screening, and see the consultant on the same day. And that's the best care, and we want to make that equal and accessible to all of Greater Manchester. At the moment, that provision of diagnostics, intervention and surgery exists only in Wigan, Bolton and Wythenshawe at the moment. So on the east side of Greater Manchester, we really need to provide some more, to provide the same level of service. But you can't provide this everywhere because of the fragility of the workforce, unfortunately, and that's why we need to combine radiologists in particular, but not exclusively radiologists, but that's where we need to concentrate the expertise. So 3 hubs is proposed. As I've said, one of those hubs must always be Wythenshawe for the reasons I've described, and therefore your choice is wanting to keep this on a geographically equally spread basis to address transport issues and access issues is one in the east and one in the west of Greater Manchester. So on the west side, the options are between Bolton and Wigan, and on the east side, the options are between North Manchester General and Tameside. And those are where we're at the moment, and the decisions around this will be taken later in the year by the Joint Commissioning Board, but we're working through the rationale for the options with, and describing those to people, and also the pros and cons of all those options are being explored at the moment. I'll pause there and go back to Anthony to finish off.
Okay, thanks, Jackie. So Jackie's just described the options. What I thought it'd be really helpful to do, and this is a quite complicated slide, so I've zoomed in the next slide on actually where we're at. So without going into the detail of this slide, what is important to say is that NHS England describe a process that we as NHS organisations must go through if we are looking to change the way services are delivered. And that process, which is described in guidance, is articulated on this roadmap. But what's important to note in terms of where we are at, and we've taken a little bit of the roadmap in this slide just to give you a sense of where we're at, is we're right at the beginning of this process. So we've developed a number of proposals. Those proposals have now produced some options, and where we are at is the point with the red arrow, which is we've got a number of options. We're doing lots of analysis to understand, is there a preferred option out of the data and the information that we're collecting together, and if we can come to a view as to whether there is a preferred option, going back to that slide. So are we able to point, so you'll see in all of the specialties bar breast, there actually is a preferred option. There are a number of options in breast. So the process that we're going through at the moment is, can we point to a preferred option? Can we then have a discussion at the JCB where the JCB confirms a preferred option? And if JCB confirmed a preferred option, we would then move to the next bit, which is after the kind of chevrons, which is developing a pre-consultation business case. And that's described in NHS England guidance. So what we would do, subject to the Joint Commissioning Board being able to say, yes, we agree with that as a preferred option, we would develop a pre-consultation business case for each of the specialties, and as part of the development of that pre-consultation business case, we would be having discussions with you as a JOSC about what those pre-consultation business cases are saying. Because part of the judgment that we need to make is, as we have previously, do we need to do formal consultation in addition to engagement with our population, or are we able, as we have done in some cases, move? We don't need to do any formal consultation. We just need to evidence strong engagement to then move towards a final decision, or a further decision at the JCB, which is the point at the right-hand side just before the chevrons. So that's the point that we are at, and this is the kind of whole journey, if you like, that we've got to go through. Right, so just to reinforce, we haven't taken any decisions yet. We're working up, hopefully, towards taking a decision. That decision, in the first instance, will be taken by the Joint Commissioning Board. Just so you're aware, each locality in Greater Manchester has a seat on that joint, in fact, they have 3 seats on that Joint Commissioning Board. There's a clinical seat, a political seat, and an accountable officer seat. Each of the localities has a vote on that Joint Commissioning Board, and that vote has to be agreed between those 3 members. So once we get to a point where the Joint Commissioning Board considers any preferred option, that will be considered by each of the 10 boroughs. What's really important for Councillor Gruby's benefit is, of course, they are Greater Manchester commissioners. Once we get to a point of agreeing the need to develop a pre-consultation business case, there will be an opportunity, and there's been some informal opportunity already, to engage with local authorities outside of Greater Manchester to ensure that those views are captured in the development of that pre-consultation business case. Okay, so I'll pause there and happy to answer any questions that we can.
Before we start the questions, a couple of comments, please. Anthony mentioned respiratory and cardiology. He's right, they're not surgical, but they're 2 of the biggest killers in Greater Manchester. So we've got to rationalise the service there. I've just used a word which I absolutely detest when I say rationalise. It's about putting the right care. You know my strapline. Have the right care in the right place at the right time within the budgets we've got. It's a real world we live in, not a theoretical one. I want everything at Wigan. Well, I don't actually. I want it at Salford. But I have to say Wigan because I live there. And all of you will be fighting your own corners for your own boroughs. I understand that. But I'm asking you to pull up that slide with a proposed site specific. Have that one in front of you when you ask your questions, because it's going to be very, very pertinent. Jackie mentioned benign neurology. I think we've been working at benign neurology for well over a year now. But there are others, like the paediatric surgery. It's logical that it goes to Manchester Kids. That's very logical it goes there. The vascular, again, MRI, what is it, Vince Smith is possibly one of the best vascular surgeons in the country. So if any of you had a vascular problem, you go to Manchester Royal. The neuro, again, logical. You also mentioned that we've done some of this previously. The trauma, those who've been on the committee a while, I think the first one we went after was the strokes. And I remember there was a lot of resistance when we said, either go down Salford or Oldham and put the scanners in. We've now got, I believe that's been like 160 people alive that wouldn't have been alive without doing that. So none of us like change. I'm the worst of the lot. But I'm also realistic. If those 160 were either mine, relatives, something like that, I'd want that change. So I ask you to start from that level. Okay, questions. Keith, you had yours up.
Yeah, thank you. I'm not quite sure it's a question, but a couple of comments
Statements.
mainly.
As long as there's a question somewhere in there.
Right. We actually took this to Stockport's Adult Care Health Scrutiny Committee last week. Presentation from one of our clinical commissioning group managers. Not to this level of detail. It was overall process and led to a really good discussion. I think the lady who came along was, I won't say shocked, but she was probably pleased at the level of involvement. People really did want to understand what was happening because, and I was able to introduce it exactly as Anthony commented, the impact of the changes to stroke services and the lives have been saved by that. I think that was a really powerful argument. Really good discussion. They wanted to know about the detail of individual programmes, and we're making sure that that's available for people who want to look at the additional level of detail. One of the comments I made was the workshops, local involvement, and there were certainly a few people on that committee that would be really keen to get involved in those ongoing discussions. So if that's an opportunity, that would be great. And we have asked the lady, Gillian, and I can't remember her surname, to come along later in the year to give us an update on that. So that was really good. Right, if I can, comment on the breast surgery programme. As colleagues may know, in a previous existence, I was involved in setting up the breast screening service across Greater Manchester. And I well remember the difficult discussions we had between Wigan and Bolton at that time, both of whom had really good clinicians. Bolton, I do remember, had a lead surgeon who was superb. Wigan had a consultant radiologist and the team around them. So I admire the problem, and how you will decide it, I have no idea. But the crucial thing is working with the groups of clinicians, because it's, you know, breast surgery, as with screening, you've got to have surgeons, radiologists, radiographers, pathology, and the whole administrative structure as well to make it work.
Yeah, absolutely right, Keith. Get off. Absolutely right about having that team together, but it's almost, yeah, basically you should know it's facilities management. Now, you know, Wigan versus Bolton. Jackie and I can size off about this afterwards. Who's got the premises, facilities available now? And what will it cost to bring them all up into line? And I hate to say it, but it comes down to something as basic as that. You can have all the clinicians, radiologists, the whole lot there, but if you haven't got the right place to deal with it, we can't. And I think at the moment, that is one of the major considerations about whether or not we can facilitate it at Bolton or at Wigan. Again, as I said earlier, we'd all fight for our home place, but we're realistic. Not everybody lives there or there. They live somewhere between the two hospitals. Ray, you were next, thank you.
The process that we need to follow first, we need to go through NHS England's assurance tests. They'll agree or not, as the case may be, that you've cut the mustard in terms of clinical evidence, patient choice, patient involvement. It's safe and it makes sense. It's at that point, and only at that point, are we then going to come to share that with scrutiny, and it will be to come and ask, do you feel this is a substantial variation based on where we were, what's being proposed, and if as scrutiny you would want to scrutinise that. I think there'll be some quite obvious go out to formal consultation on some of those. By the nature of some of those services may well create a wealth of public interest, as you said, has happened at local authority level. So it is to come to you and take your advice and listen to your thoughts, and we will work alongside JOSC and the requirements laid out.
Having experience, it's the breast cancer and breast screening really. Having experience, I lost my wife 18 months back with this. She got the all clear from Oldham in the April and died of liver cancer in the December. I just wonder at this moment in time if the actual quality of care was held at Bolton where they had the operation, did they at that time have all the equipment to do a full body scan? And if not, why not really? But it's not a personal question, it's not casework. But I would want to ensure that any breast cancer screening could be done on the one site for all cancers, not just necessarily the breast cancer. Can that be ensured?
We're certainly trying to provide a service across Greater Manchester that has a comprehensive service in 3 places. I can't speak for your sad circumstances, I'm sorry, And there may have been other issues there. But I think for the actual model of care, that is very much the intention. I should also have said that this doesn't change the public health screening programme. That will remain as it is. So all the mammography that happens, and people don't need to go on because they have a clear mammogram, that is all in the same place, intended to be in the same places as it is now. So that you'll have very local access in your locality to mammography. It's more the once you've been either have found a breast lump, have breast pain, or the mammography is positive and needs further investigation. It's those patients, so it's a smaller subsection of patients that go on to have the full investigations and what we call a one-stop shop, which is basically everything done all in a day and all the appropriate scans that you need.
In actual fact, Ray, if you think back to what John said earlier on, diagnostics are helping prevent. Like you, I know exactly the same pathway for the same reason. Jackie, if we had a goal from this committee at the moment about breast cancer, it's to get that initial screening done 10 years earlier. If you think about the number of women's lives we can save, because 1 in 9 women are being picked up with breast cancer at the moment. 1 in 9, of which I think it's 24% don't survive out of the 1 in 9. So basically, I'm trying to remember what it was like. It's about 2% of the females will die of breast cancer. And that's sad, 2%. Now, if we were picking up earlier, so if we had one thing that I'd like to say, aim towards, is that mammography is done not when they get to 50, but it's done when they get to 40. It's a big shout because I appreciate what John said. Diagnostics are the thing that's delaying us at the moment. Getting scanning, getting radiologists. One-stop shop. Once somebody's been diagnosed with breast cancer, there is a regular follow-up of, you should know this, they're on the radiotherapy or chemo, and they're on 3-monthly scans. Then when they've got to a certain level, without discussing a specific case, it's unfortunate it progressed so far, so quickly, as you appreciate. Sophie, you're next.
Thank you for this. I am very much in favour of this model and this streamlining of services. We've learned it in Trafford, and I think there was a lot of resistance. Perhaps you think back 5-10 years ago in Trafford, but I think we've seen the outcomes, particularly from Salford. I'm just thinking about the patient experience in all of this. I do believe that this is a correct way to proceed, absolutely. But thinking about, if there are central hubs in particular parts of the conurbation, just about the patient experience in accessing some of those services. And, if you live in Wigan, have to get to Wythenshawe for that. It alludes to what you were talking about before. Has that been considered? We were even talking about car parking charges, those are things that are really important to service users, aren't they? What consideration has been given to those kinds of
Okay, so in the models of care, very much the intention was to try and keep as much local as we could, but also get the benefits from consolidation of things that are very complicated, be they diagnostics, operations, etc. So the actual movement of patients is not going to be very significant. I can remember the statistic. I can't remember it off the top of my head. 6%, I think, of all the activity in Greater Manchester. So it isn't much because we are trying to keep most things local. That is certainly the case in urology. So day cases, outpatients, etc., still stay within your locality. So that was in the minds of the clinicians and the patients they spoke to when they were developing the models of care. So there was a fair amount of public engagement whilst they were developing the clinical models, and subsequently the work that Jackie does with the public is testing this out. So what we're saying is for very complicated one-off, once-in-a-lifetime interventions, yes, it's more likely you would have to move across Greater Manchester or travel across Greater Manchester. But we're minimising the amount of activity that involves. We've also got, as part of the evaluation criteria and in terms of helping us decision makers as we move forward, very, very comprehensive travel time analysis done with Transport for Greater Manchester. So that will help the commissioners come to some decisions about what the best thing is in terms of access and travel.
Eddie.
Thank you. Perhaps I've been on this committee a bit longer, I might not ask this question, but you do say that the feedback from patients and the public reference was extensively supportive. 80% supported it. What's that number? What 80% of what?
560,000 people who've had it.
The patient public reference group, that actually refers to the models of care. So they understood the need for change. They understood the decisions that have been taken so far. And overall, they said we would support those models of care. What we've not, until Monday, spoken to the reference group about was the site preferences. And that only happened literally 2 days ago. So the analysis, that's not there. But in terms of equity, every clinical commissioning group is represented through 2 patients. Every health watch across Greater Manchester is represented. We worked with the voluntary, the voluntary community sector to advertise engagement to 1,400 community voluntary sector organisations. So collectively, they are a representative geographical spread. However, they are not the voice of the population. You're absolutely right. And if and when we come to a place that we need to do more engagement or formal consultation, every clinical commissioning group have the responsibility to engage their local communities. So it will go to the heart of the people in the locality, but will be driven through the commissioners. So this is bringing collectively people together, sharing that overall picture, getting a sense of kind of taking the pulse of the public really, and that's the stage we're at.
I think quite a few of the things have actually been answered already, but I think, you know, in the past we've stressed, haven't we, that, and you alluded to it, Jackie, it's important that the starting point for the public is what actually is going to happen in your area, what actually is still going to be in your local hospital, because when you start talking about taking services away, people panic and they start saying, are you going to close our hospital? So I think, you know, say this is what's going to happen in your local area. And then the next point, obviously, is to say, look at the good outcomes of places like Salford. I don't, certainly from our area, people will say, if they've had a stroke, take me straight to Salford, you know, if this is a centre of excellence, which is what happens. And the other bit, and Jackie sort of reassured me a little bit, is about the screening, really, because I know even in Bolton, although the diagnostics is on one side, the screening is actually in Bolton 1. It's on a different site. It's not all, and that is a bit that we really need to keep really, really local, because we don't want to deter anybody because of travel or whatever, not going for screening for breast cancer. And you know, I think it's been raised before. So transport is pretty good in and out of Manchester, transport-wise, but across Manchester, Greater Manchester, it is not good. So even getting from Wigan to Bolton, and I'm sure as you're going round the conurbation, we're not good on public transport and stuff like that. So as close as you can keep the screening to people to ensure that women do go, because, you know, the slightest little thing will put people off from going. That is quite reassuring, really.
At the earlier meeting, Linda, it was raised then about, not only about public transport, but about when you get to the hospital. If you've got, the comment we put on record, if you've got a condition where you're going to the hospital repeatedly, the parking charges, for example, are made free. If somebody bothers to tell the patient that happens. But you're getting people now with multiple clinicians being treated, and they're not being joined up. So we might have to go to a hospital 3 times in a week, but there's 3 different departments. And we need the hospitals now to start, especially with this, to start joining that up. So it's not just about people coming on public transport, because you're right, it's one thing going from Bolton to Manchester or from Wigan to Manchester, but trying to go in between those hubs is pretty bad at this point in time. And therefore, more and more people do use private transport, and we've got to make provision. I know it's income generation, Jackie, but come on, if people are going to 3 patients a couple of times a week, that's a lot of money. That's 30 quid or so. What, Margaret? How much did you say it was costing you?
Well, one of our councillors.
Apologise.
As I say, it took me an hour to get here this morning, bus, car and tram. So if I had then to go on to Wythenshawe or wherever, then it would be even... And if it's a traumatic experience for families. So my daughter, when I went to Wythenshawe, my daughter come with me. So if I've been going by bus or tram, double the fares there and back, and people, it is a difficult situation. But what I wanted to say is, as Anthony knows, in Salford this is called skin and hair to fly. Been lots of discussions, but we can't be parochial. It's about what is best for where will people get the best treatment. I want to raise 2 points if I can, John. One is about the different CQC qualities in hospitals and our standards in hospitals, and the other one is about MRSA and C. diff. I mean, you can have the best surgeons, the best treatment in the world, if then the standards outside, in terms of C. diff and MRSA, they can kill you just as quickly. I do want to echo Ray's a point. My brother had lung cancer, and he had excellent service at Wythenshawe that completely got rid of all his cancer. Of course, it come back, but then he went to 4 different hospitals, and his notes were at Wythenshawe. His notes didn't go with him. He subsequently has died, unfortunately. But it's that aftercare that I'm concerned about. Yes, get us through the surgery. Yes, have the best nursing standards, but it's the aftercare. There has to be continuity. People, if they're operating in Bolton, need to see that consultant for that aftercare, not go across the city.
Margaret, if you remember what I said at the beginning about the strap line, the best patient care in the right place at the right time, but it's always been, and Anthony had quite an earful about this last week, it's the follow-ups. The follow-ups must be done locally. I refuse to accept that we need to send people from, say, Tameside to Wrightington for follow-up after a hip or a knee. It's disgusting to expect somebody who's already suffering to travel those distances. With the breast cancer services, the quote I made was the fact you've got somebody who's physically and emotionally traumatised by surgery. It is quite traumatic, as Ray's commented. We don't want them to have the added thing of having to travel long distances. When we did Making It Better, when we talked about maternity and neonatology, we asked all the mothers, how far will you travel for the best patient care? They didn't care. They didn't care. What they wanted was their child fixing. I'm sorry if that's a bit crude, but that's the fact. They wanted the best treatment. But once that major problem has been solved, it needs to be done at your local DGH. And we must make provision. Because at the moment, I had a case of a resident complaining only this week. They're in hospital. They've broken both humeruses, both upper arms. They're discharged in slings. They get 3 days of hospital at home. And they're told they've got to pay for the care after that. That is disgusting. £15.40 per hour. And I say, John has this on record from earlier this morning. But Jackie, it's not good enough. We've got to have some joined up writing now. You can't move people around and then not have the care afterwards. Keith, you've been very patiently waiting.
In fact, it pretty well has been covered. The need, I think people well recognise the benefits of going to a centre with real expertise. The comment I've heard is, would you rather have your surgery done by someone who will read the textbook the previous day or someone who's doing it a dozen of times a week? No question. But it's once that's happened, ensuring that the rehabilitation, the ongoing activity happens as local as possible. And I remember last year the discussion we had on the neuro-rehabilitation made exactly that point, and I think that's worked really well. So key point, well made.
On the subject of transport, trying to get from Bury to Oldham is a nightmare. Never mind Bolton and Wigan. No, I've got 2 questions really. One's just clarification, and that's the cardiology, which you've got now, is under review. But it's separate apparently from the vascular. Now, is this because you don't count bypasses, for example, as cardiology, or are they vascular? And is it not part of the same? You know, I've always thought of it as being cardiovascular put together.
Well, yeah, it's a good question, because you have blood vessels all around your heart,
Yeah.
and one the heart supplies the blood vessels, so I can see why you ask. But no, in vascular, in these terms, is about operations on the major artery that runs through your abdomen, and the major arteries in your neck. That's essentially what would happen. But the cardiology is very much still bypasses. But in this piece of work, it's more the medical side of cardiology that we're looking at. So it's about how we manage chest pain and breathlessness in local communities.
Pacemakers, installation of pacemakers.
Yes,
that's
that's
now
also
considered fairly minor surgery these days, isn't it?
That's cardiology, and that will be addressed in this programme.
Thank you. So my other question really is about basically anecdotal evidence that you get from family and people around, and I dare say it's possibly a staffing problem as much as anything else, that you really have to be very bad before you can get surgery. You know, people go with bad knees in one time, you say, yes, you will need a knee replacement, but you're not bad enough yet. And the same, although it's not in this category, the same goes for cataracts. You know, your cataracts aren't bad enough yet to need surgery. And I've always thought, I realised that it wasn't under any of the constraints that you mentioned, that there might be constraints that made thresholds for actually requiring surgery, perhaps a little on the high side. And I just wondered if you had any comments for that, because I don't know whether that's just financial or capacity. But surely the earlier people get this stuff done, the cheaper it is and the better the outcomes in the long run.
So it's probably for me and Anthony, that one. So I'll start with a clinical explanation, I think. It's a mixture of things that people, that we address thresholds, so capacity can be an issue. But actually there are clinical considerations, because there are complications to any intervention, and particularly surgical interventions. So you balance the risks of how much the operation is required in terms of its impact on lifestyle, to the risks of quite significant complications from surgery. So I think there is, to be fair, a fair old clinical risk evaluation that goes on in determining thresholds.
Yeah, and just so we're clear, the judgment that we make as commissioners is based on clinical evidence. It's not based, fortunately yet, on, certainly not in Greater Manchester, on financial considerations. So, I think Jackie's right. So there is a huge amount of evidence that suggests that, so for example, back pain, that surgical intervention for back pain has to be a last resort because of the dangers of that type of surgery. Physiotherapy and other therapeutic interventions over a period of time have exactly the same potential to improve back pain as any type of surgical intervention on your back, which would have to be considered as a last resort because of the risks associated with it. But I think I'm really pleased to say that, my understanding is in Greater Manchester that there is currently no, if you like, rationing of services based on financial need. It is these are all judgments made by clinicians with other clinicians about need and threshold.
Thank you very much for that, and I do appreciate you have to do a risk-benefit analysis on any operation. I follow all that.
I mentioned a guy called Vince Smith earlier on, Smythe with a Y. He's only got two passions in life. One's vascular surgery and the other's golf. And if you get golf into theatre, you'll be doing it at the same time. This is about having the right people to do the right job. You say about travelling. Are you prepared to travel 20 miles to get the right person? We did an analysis about 5 years ago over vascular surgery. And we looked at each DGH, how many did you do? Now, I can tell you of one hospital that when they were asked, they'd done one carotid artery in a year. Vince had done 102. I ask you now, which hospital do you want to go to? It's a no-brainer, but we haven't got lots of Vince Smiths in every hospital. There just isn't the number of surgeons. That's what this is really about. Yes, we're all very cynical about money, etc. But the reality is, not only do we not have the surgeons, we haven't got enough nurses to have this in every hospital. It's not a perfect world we live in. So I ask you, members, we're running out of time, but I ask you now, you've had a fair hit at this. Do you accept this programme at this point in time? Can they move forward to the commissioning team on the 16th? Thank you. Now, before the spring break, you and I might have been meeting, but a lot of the members stopped in March. We did some training for members, and approximately half of the committee managed to get to that training. Do you want to offer a more in-depth thing about these now?
So, John, we can do whatever is helpful. So, we had, I think, quite a helpful session at the fire station a couple of months ago. If that would be helpful to do that again, particularly for the new members, very, very happy to do that. Interestingly, we're also, so I'm just about to go to Stockport, Keith, so I'm not quite sure who I'm meeting, but I think, a locality has asked for some perhaps more in-depth briefing. So, and Margaret and I have had lots of conversations in Salford. So, well, yes. So, whatever would be helpful, perhaps give us.
How many of you would like a more in-depth session rather than a scrutiny meeting? Can we show of hands, please? You did the last one. There'd be nothing different. Eddie, you weren't there. Ray, you couldn't there. Margaret, Sophie. Right. So there's 4. I'd be there. There'd be 5 people if you could sort out a date between Lindsay and the members, please. Thank you.
Just a quick one, Chair. On your neuro rehab, you've got hot site, warm site and cold site, so just want an explanation on that, if you wouldn't mind.
I'll try. So it's probably unfortunate language, really, but what it means is, so if you've got the most acute need, so if you've had a brain injury, for example, so obviously our neurology and neuroscience centre is in Salford, and if you're recovering from that brain injury, but still need some specialist help and support, then you'd have that in Salford. Hopefully you'd start to get better. Hopefully you'd start to rehabilitate, but and you might be discharged back home, but you might still need a period of hospital care as you start to get better. But as you are getting better, you might not need to go to Salford. You could get perhaps still some good care, but not from the super professionals, but still from people who know what they're talking about, and that would be at the warm site. And then as you continue to get better, you might be doing some care at home, but you still might need perhaps a period of time in hospital for some intensive rehab. As you continue to get better, that might be then delivered in Rochdale to help your care. But of course, that might not be about a journey. That might be that you have a brain injury that is significant, but it's not the most serious, and therefore a clinical judgment would be made. Yeah, actually, the best place for you to be looked at, given the nature of your injury, isn't Salford, it's Trafford, because they're the right people who can look after you with the type of brain injury you've got. So it's the same principle, concentrating the expertise in the right place to ensure that you get the best care.
Yeah, very quickly. Key to this is what Ray and I were saying earlier on. You must then allow that information to pass to whoever's treating the patient. From the consultant, from the surgeon, down to the physiotherapist. They must all have the consistent information and not be scrabbling around for notes.
Okay, it's a point well made, and frustrates as I'm still practicing in medicine and see patients on a regular basis, and it is a very constant complication for clinicians and for patients. So there's a lot of effort going on across Greater Manchester to join up our technology. It's not perfect and it's not there yet, but there's definitely an intention to do this. We have got to the stage now where we can at least share images across all the different hospitals and organisations, but we need to be able to share the records with the appropriate information governance and security around that.
In actual fact, Jackie, we had Stephen Dobson in twice now. First time he asked for 10 million, then he asked for 18 million, now he's up to 30 odd million to get the writing joined up. There's something about IT people, I know we're on record, but I'll still say it. Something about IT, when we want to get the perfect model, it is on the work plan, or will be on the work plan, for him to come back and explain where we're up to. Jackie, the problem isn't necessarily the IT. The problem sometimes is the clinicians. I was talking to one yesterday, and he didn't know that you can access scans from another hospital. And I think we've got to spread the word as much amongst some of your colleagues about what they can find and what can't. Many of the questions that the members ask can be solved if we know locally about it a bit better. I thank you for all the time you spent. We're running tight, and I've still got 3 items on the agenda. If you wish to get on to your next meeting, I appreciate it. And we'll speak, Anthony and Jackie, you know where to get hold of me. Yes. Thank you. Thank you all. Right, members, I'm going to have to push on this one. I skipped over the terms of reference at the beginning of the meeting. It's for noting. Joe Heron here is going to be rewriting them, and we'll bring the revised terms of reference to another meeting. So don't worry about that. Dates of future meeting, I'm jumping right to the end there. You've got them there. Any extra meetings like the training will be notified. Now the work programme, I've just touched on it. We have got already penciled in, but not in writing here, ambulance service. They've got a new chief exec. Derek came here twice and got challenged, I think that'd be the polite way of putting it, about the service delivery. We've now got a new chief exec there, and we've been offered the chance to go down to Parkway, have a visit of how they run the control centre, and hold our meeting there. So it won't be 2 bits of travelling. It's not an extra meeting. So we're putting that in. The IT I've just mentioned, we need that sorting out. There are a few other points, and we will fill them in and send them out to you. I'm sorry to rush over the last bit, but I'm conscious you've got to get on elsewhere. Margaret.
Just very briefly, John, I found that briefing from the Health, from the Health and Commissioning Board, if we could have them, say, kind of twice a year, that would keep us up to speed with what they're discussing.
If we come up with ideas, shall I just send them to you? Yeah, because I was thinking of the large amount of money that we've just put into a bed for every night through the commissioning board. Not for now, but probably for 12 months, for the end of the year, to see how that money's been spent. And yeah.
We'll get you a copy of this. There are some very, very good points you might want to pick out. One of the ones I've asked for a report on is the one about the children's mental stuff. I know nothing about that, and I've been around acute, healthcare for 40 odd years. So I think there'll be other members who'll be in the same boat. Margaret?
No, I agree with what you're saying, John.
And we need that bringing in. It's one of the most significant achievements has been the GM Mentality Healthy Schools pilot. Anybody knew about that? No. So we need a report on that, please. And things like that. So if you feed them back, we're very grateful. I thank you for your time. And sorry, Sophie.
Really quick question. When is it yourself and Margaret will work on the plan then, and then when will that be shared then? Or
Next meeting? No, before that.
We're putting our plan together in Trafford, and I'm just thinking if there's anything from this that might inform our work.
Yep.
I mean, we've more or less finalised it, but if we could maybe weave any of this into it, it might be useful.
If you send it to Lindsay and Joe, Lindsay will coordinate it, I think.
I'm thinking the plan from here coming to me, really, is the way around.
Yes.
The GM plan coming to us.
I've made notes of everyone's comments. What I would suggest is I draft a work programme, send it out to the members of this committee, in the next week or so, have a look at it, get back to me if there's anything you want deleting, adding, and then we'll have that. It's a living document, it's not written in stone, so if there's changes to it, but then that might help you inform your district.
That's great, thank you very much. That's what I meant, thank you.
Safe journey home.